We now change again a bit the topic. After distal proximal weakness, we come to ventilatory aspects of neuromuscular disorders. And it's, of course, a pleasure to introduce my colleague, Stefan Wenninger, working with me since many, many years. And he made it in time, so I'm lucky. Because if I would give that presentation, you would leave the room.
The pilot made it in time. I was just sitting in the plane, so. Welcome. These are my disclosures. I don't have to talk about this because they're not relevant today. This is the first slide you can see on the screen, and I did this slide last year, and I did it like a quiz. And it took so much time, so I'm now just presenting this slide because I want to get you back into your own physiology. What happens in you when you activate your muscle? Just think about you. How many of you are doing sports at least 2 or 3 times per week? Hands up. There should be more hands. There should be more hands. Okay, so this is something what you normally experience when you do sports, doing treadmill or something like that. Your heart rate increases and your respiratory rate increases, and with this your blood flow increases. But why? Just because your muscles need more energy, they need more oxygen, and they produce CO2. And with the CO2, we have to increase our breathing frequency and breathing depth to exhale our CO2 and inhale our oxygen. And this is the point in neuromuscular patients where this system doesn't work anymore, because with more muscle activity, even in patients who are very stable for a long time and have only a slight ventilatory insufficiency, they might develop a respiratory failure because this system is something like a vicious circle. They try to produce more energy by the muscles, and with more needed energy of the muscles, they need more oxygen. They can't give them more energy by oxygen because their pump, the muscle of the respiratory system isn't working anymore, and so CO2 increases and O2 levels decrease. And this is what we see on intensive care units in patients who develop respiratory failure. So the main function of our lung is the exchange of gases, primarily oxygen and carbon dioxide. And there are many other factors that are involved in this, but these are the most important ones and the most easy ones to understand. And the respiratory system is a very fine-tuned network. And I think you can see this in any patient or even with yourself. If you start breathing too fast or too slowly, I'm sure you develop symptoms very fast, very quickly. So this fine-tuned network might be out of work or out of function when pacemakers or chemosensors or any small part in this fine-tuned network isn't working. And in neuromuscular diseases, we have to distinguish between the central nervous system, where pacemakers and chemosensors are relevant, the peripheral nerves, the neuromuscular junction, muscles, and of course a sufficient airway system. The respiratory muscle involvement, of course, is the main cause in hypoventilation in neuromuscular diseases, but we have some neuromuscular diseases where we know that there is a blunted respiratory central drive, and these patients develop nocturnal hypoventilation just because of altered functioning of these central pacemakers. But in most patients, we know that the lung tissue is healthy, and the respiratory involvement is just because of respiratory muscle weakness. So in most patients, oxygen levels are for the long time normal, and CO2 levels increase. And this is a first problem we have in daily routine practice. We don't measure CO2 levels unless you do blood gas analysis. So typical physicians, they just look for peripheral oxygen on the finger clip, and this is a long time normal in these patients, but CO2 can already be elevated. So the first recommendation is in neuromuscular patients, do blood gas analysis, because you might detect respiratory involvement very early in these patients. But there's another problem in these neuromuscular patients. As long as they are awake and as long as they're walking around, you might dismiss these CO2 elevations because it can be compensated very easily during daytime. And what you see on daytime is not the truth what might happen in the nighttime. When we just look at the hypoventilation symptom, we have the impaired function of the respiratory muscles, we have an impaired respiratory pump, and we have a shallow breathing in these patients. So we have an impaired gas exchange and airway system. And I know it's very small on the right side, but this graph is so important to understand our gas exchange system in the peripheral blood. You all might remember from your university, your college, the Dalton's law. Yes, you do. Hands up again. I have to keep you more active before the coffee break. So hands up. No, you don't remember the Dalton's law. Oh my God, so this is very important. This means that if you have CO2, an increased level of CO2 in your peripheral blood, you can't increase your oxygen levels in the peripheral blood. So when I'm talking to students, I just try to explain this by a taxi. You know taxis? Yeah. So they have 4 seats, like hemoglobin. And this taxi is able to transport 4 molecules, O2 or CO2. If the taxi is full of CO2, they can't transport O2 anymore. So it doesn't make sense to give patients who have an increased CO2 level just to give them oxygen. It won't be transported. This is simplified Dalton's law. Okay. And with hypercapnia, with chronic hypercapnia, we have an impaired CO2 responsiveness because our peripheral and central chemosensors, they adapt to a higher level of CO2. So we have 2 types of chemosensors, the CO2 chemosensors and the O2 chemosensors. So CO2 chemosensors, they decrease their functioning and their rate of firing informations to the peripheral system. So, but what stays active is our O2 chemosensor. And now you can develop your own thinking in what happens when you have a patient with a highly elevated CO2. You give these patients oxygen, and what happens? The chemosensors that are still working for oxygen, they are firing at a higher rate and say, well, I don't have to breathe anymore because oxygen is now here where I need it, but the CO2 level is still high, so you're driving this patient into a respiratory insufficiency or respiratory failure. In short, these patients just stop breathing. So please don't ever give patients just oxygen without doing blood gas analysis. This is in red, so yeah. This means it is important, okay. And this is why I include this case report of a young female patient I had in my outpatients clinic, 23 years old. She had a slight intermittent muscular weakness, 4 months. She developed, let's say, a continuous worsening of breathing for 3 days and some coughing. She called the emergency, and the emergency doctor suspected a COVID-19 infection. And while the transport to the hospital, he gave her 6 liters of oxygen. And she developed a respiratory failure, and the doctor started a non-invasive ventilation, and she got even worse. So when she arrived at the clinic, she had to be invasively ventilated. And what happened is she had a myasthenia gravis. She didn't know about that, and she had a slight infection of her respiratory system, and this supplementation of oxygen just drove her into respiratory insufficiency. Of course, afterwards, everyone knows better, of course, but in this case, we always have to ask, do we really need 6 liters of oxygen? So normally 1 to 2 liters are sufficient in 23-year-old patients, even with slight pneumonia or infection of the upper respiratory system. So just don't be uncritical. Just think about whether you need so much oxygen, or if even 2 liters or 1 liter is enough for this patient. In many, but not in all, neuromuscular diseases, we should need the knowledge whether this neuromuscular disease will develop respiratory involvement. And it's always a little bit tricky or hard to explain patients, let's say with myotonic dystrophy type 2. We have several patients who are admitted to a pulmonologist every 6 to 12 months. And this just doesn't make sense, because these patients, they don't develop respiratory involvement. They might develop obstructive sleep apnea, but they almost never develop respiratory involvement due to muscle weakness of their respiratory system. So the knowledge whether these patients might develop respiratory involvement is essential for the treatment and their observation in their daily clinical practice. Where can respiratory involvement occur? And we have one main, let's say, disease that accounts for all these stages. Do you know that disease, this neuromuscular disease? Central, oropharyngeal, skeletal, and thoracic deformities and respiratory muscles. These are the 4 main stages where respiratory involvement in neuromuscular patients might occur. But there's one disease where every stage can occur, even in combination. Louder, louder. Myotonic dystrophy type 1. Perfect, wonderful, yes. And this is an example of a young patient with myotonic dystrophy type 1. She had daytime sleepiness, severe daytime sleepiness, and morning headache. So, by the way, do you know why morning headache develops? Do you know that? Hypercapnia. That's my topic. But why? Sorry? Too many? So it might be my presbyacute. I can't understand you. Okay, let's. So it's just the CO2 level, increasing CO2 levels. They cause a central vessel dilatation, and this is causing morning headache, which diminishes after 1 or 2 hours, typically in these patients. If the headache is longer in these patients, it's not hypoventilation caused. Typically not. So this patient has morning headache and fatigue and so on. And this is a sleep study where they found out that this patient had a central sleep apnea. And she had normal lung function. Every test in spirometry was normal. And this is something we need in patients who have normal spirometry. Don't say everything is normal, just come back in 1 year. You have to do your workup, including polysomnography. Oropharyngeal, almost all neuromuscular patients might develop obstructive sleep apnea because of the weakness of their oropharyngeal muscles. And sometimes only the partner might give the clue that the patient has sleep pauses or breathing pauses at night. Again, these patients have to be admitted to a sleep laboratory. skeletal and thoracic deformities. This is a picture or a video from Nadine van der Beek. She did a study in Pompe patients, but this is a healthy patient. And this is just a video. I just wanted to show you that it's not only necessary that the diaphragm is moving down, it's also necessary that we have a chest that is moving, that is compliant, so we can increase our volume to increase our lungs. And on the right side, there are two examples of patients who have severe skeletal or thoracic deformities. The left one is a Pompe patient, and the other ones are also Pompe patients. And I think it's easy to understand that with these severe deformed thoracics, it is not easy to breathe. And this is a patient I wanted to show you. He has a nemaline myopathy with a very flat chest. He has a lung function of about 1.1 liters. The good thing is he has no hyperventilation symptom. But if you do a spirometry in these patients, this won't be normal. This will never be normal because our normal values are based on healthy people, not on these patients with these severe flat chests. But yes, of course, in most patients, our respiratory muscles are weak, and this is what you see on the right side. I will talk about this lung function on the right side a few minutes because it's so important to understand this. We have some neuromuscular diseases where experts came together and developed recommendations. How often do we need to test lung function in these patients? And of course, we have more and more experts and more expert groups, so all these recommendations will increase in the next time, and I think it's necessary just to read them one time and to understand whether your patient you have in your daily routine practice needs lung function every 2 years or every half year, because some patients are at high risk developing hypoventilation symptoms like Pompe disease patients, and in these patients it's recommended to do this at least once a year. This is why we have yearly checkups in these Pompe patients, for example. We do have recommendations for motor neuron diseases, especially for ALS patients. We do have recommendations for SMA patients. We don't have so many recommendations for neuropathies, mainly for acute onset neuropathies like GBS or AEDP. This might be the reason because chronic neuropathies normally don't develop respiratory involvement. Normally, it's not very common, and we don't see this in hereditary neuropathies with some exceptions. A pretty high rate of respiratory involvement was published by a German group 3 or 4 years ago. This was an intensive care unit expert group, and they published their data on about 500 myasthenia gravis crisis patients, and 15 to 20% had to be ventilated. And the most dramatic thing I read in this paper was that after even 1 year, about 10% were still ventilated. So they showed weaning failure, and I think this is a very high rate. We should think about of a better treatment in these patients. And some cases with mitochondriopathies. In limb-girdle muscular dystrophies, we have some that are commonly associated with an early and severe involvement of respiratory weakness, like Foucault-related and the sarcoglycanopathies. And we have many where it may occur. And this is just a table I did 2 years ago. This is based on case reports and short descriptions on some limb-girdle muscular dystrophies. Until now, there's only one group, an Italian group, who has published registry data and on the respiratory involvement in these patients. And it's over here, it's quite the same picture as here. Most patients who were ventilated were sarcoglycanopathies and Foucault-related limb-girdle muscular dystrophies. The clinical symptoms. So if you are not interested in respiratory symptoms in patients or diagnosing respiratory symptoms in patients with neuromuscular diseases, this is the only slide you have to remember because you have to ask for these symptoms. Right now, we don't have any good questionnaire that could be used to make your work more easy with patients. Just fill out this questionnaire and I know everything about you. This doesn't work in these patients, so you have to ask these patients. We have some questionnaires for distinct neuromuscular diseases like myotonic dystrophy, but we did a study, so for myotonic dystrophy type 1, there is one questionnaire. We tried this, or we tested this with myotonic dystrophy type 2, and it didn't work. So it is very specific for special neuromuscular diseases. And you have to ask for symptoms like morning headache, daytime sleepiness, concentration difficulties, reduced muscular endurance, depression, and my recommendation, don't ask for fatigue because almost every patient with neuromuscular disease has fatigue and it doesn't give you any more information. Even I'm fatigued today. So, okay. Symptoms that are associated with sleep disordered breathing, you can't ask for them unless a partner sleeps beside them and tells you, well, he has breathing pauses. So this is something you have to figure out in sleep studies, to be honest. But you should, a red sign should come up when patients show you an insufficient cough, and this is something you can test every day in your patients. Just 1 or 2 times coughing, and if this coughing gets weak, you can assume that his breathing system might be impaired. And advanced stages, orthopnea, exercise dyspnea, and dyspnea on immersion on water. This is something I really want to know from you. So you're prescribing physiotherapy to these patients, almost all of you, I think, right? So how many of your patients are doing water physiotherapy, like aquarobic or something like that? Do you have this? This is... Yes. And do you have patients that say, I don't feel comfortable in this? Yes. So this might be a clue that diaphragm is weak, and as soon as the water immersion reaches the diaphragm, the patients are feeling not very good if they have to breathe in the water. So this might be a sign. And recurrent respiratory tract infections due to weak expiratory muscles. These patients develop just recurrent respiratory tract infections. This is also a sign. This is your main job. Ask for the symptoms. As always, just talk to the patients. Okay, what can we do? How to assess it? Next question for you. So you remember this is a course, not a lecture. You have to work with me. Hello? Okay, so has every one of you ever done a spirometry? Hands up again. Okay, was it easy? For who would say it was easy? None of you. It was very exhausting, right? Okay, think of it if you have a patient, sending him every 3 months to the pulmonologist, just do your FVC, please. I need your FVC. Okay, doesn't make sense, honestly. So the forced vital capacity is a very good test. It's a very robust test, and it's a frequently used test. But it's also a global test of the whole respiratory system. And this is a little bit tricky to understand, and this is why I spent a little time on this. The next thing is maximum voluntary ventilation. Has anyone done this of you? Anyone? MVV? It's more exhausting than the FVC because you have to breathe in a perfect rhythm for, depending on the laboratory that is doing that, for 10, 12 seconds in a perfect way. And if you don't do this, the test is not valid and you have to do it again. And this is not very motivating. And of course, we do the blood gas analysis. And the most important value for us is CO2, of course, but we also need basic SAS and oxygen and hemoglobin and so on. And the problem is, In chronic diseases, the respiratory insufficiency leads to a slowly progressive elevation of CO2, has very unspecific symptoms at the beginning, and may be compensated during daytime. And the significant changes in blood gas analysis, they might occur very late, sometimes too late. Good. This is an FVC. The blue curve is the sitting curve, and the red one is the supine curve. Who of you is asking for a supine FVC from the pulmonologists? Oh, wow, that's not so many. Okay, so this is important in every neuromuscular patient. Just request it because with a severe drop of the FVC between sitting and supine, more than 20% indicates weakness of the diaphragm. And there are not so many diseases that have a weakness of the diaphragm. Do you know what? Oh, it's over there. So it's already written. Oh, miss. Okay, so it's Pompe disease and so on. So I think everyone can remember these. So if you see these curves, this is another question. Even in our university clinic, we don't see the graphs from the spirometry. Do you see the graphs? Or just do you get the values? You see the graphs. So we don't get this. This is ridiculous. Okay. And this is the most important question. I'm so happy to ask this question. So this is a normal FVC curve. You know we have to do this at least 3 times, and these 3 times have to be reproducible, so we don't have too many different values or results in this. Do you know where is the FEV1, the volume that is exhaled in the first second? There are some numbers, 1, 2, 3, and 4. You see this? 1, 2, 3, 4, and 1, 2, 3, 4 on both graphs. Where is FEV1? You say number 3. So hands up for number 1. Number 2? No one. Number 3? No one. Almost no one. Number 4? Okay, most of you just don't want to play with me. Okay, so it's number 1. Do I have a pointer here? Yes. So this one indicates the volume that can be exhaled in the first second. So 0 seconds, 1 second. If you go this 1 second up, there should be your curve, and you should exhale most of the volume in the first second. Can you remember any trial that missed this value, the FEV1? This happens. This happens because they didn't look for the curves, they just looked for the FVC. It happened in a big trial. A big pharma company did this small mistake on Pompe patients. They just evaluated the change of FVC from baseline to the end of the study, and they didn't look for the FEV1. But the FEV1 tells you more than one thing. The most important thing is the compliance of the patient, the lung compliance of the patient. And if this the compliance decreases, you have to think of concomitant diseases. So what we are treating in these patients, we are treating neuromuscular patients that might develop also other diseases, concomitant diseases like COPD, like in this patient. And this patient just caused, we can see this now on post-hoc analysis from this company, this patient caused a non-significant result in FVC because he had a severe, untreated or not very good treated COPD, and this decreases your FVC. And this can only be seen if you just look at on your curves. And if they did, they could have seen that this patient should have been excluded before the final analysis. So, to make it clear, one patient, if you're doing clinical studies with lung function, just look at the curves because one patient can kill your whole study. And this is why we have to figure out, or why we have to understand that spirometry is not only FVC. FVC doesn't reflect your breathing system because your spirometry, your breathing as a global assessment is not only because of FVC, fast exhaling, it's also inhaling, it's your respiratory tract system, it's your compliance of the chest, it's your compliance of your lungs. So it includes many more things. And on the right side, just to tell you, it might be really a bad day for some patients and for you as a treating physician. On the right side is a patient with a myotonic dystrophy type 1. He just didn't understand how to perform this test. So you can't read out anything on this FVC tests. Okay. So we have to ask for the symptoms, and one other test we can do, but it's very debated whether should be included or not, because it's a voluntary test and it's very like the 6-minute walk test. You might have a bad day and bad results, and you might have a good day with good results, is the maximum inspiratory pressure and expiratory pressure. These tests directly reflect your strength of the muscles of the inspiratory or expiratory muscles by a very small device that is a handheld device, not so expensive and a very easy test, but the results might change dramatically. So if you do a maximum inspiratory or expiratory pressure in these patients, always do more than one test and try to figure out whether this patient is understanding what he should do. And this is a pressure curve over here. The patient inhales against resistance, holds this for a few seconds, and then exhales. And this pressure curve is our indicator whether the strength of the diaphragm in this case is sufficient. If you do both things, you increase your probability of detecting respiratory insufficiency, FVC and MEP. We've shown this in our study, and this goes back to LaTroya. He published this in 1980, which is very interesting and very important. So he had neuromuscular patients with respiratory insufficiency, and he just did some very sophisticated calculations. And what you can see here is that patients with a severely reduced inspiratory muscle strength in percent predicted might even have a normal FVC. And this comes to the end that maximum inspiratory pressure correctly tested might indicate respiratory involvement earlier than the FVC, because FVC is a global assessment and MEP is just the assessment of the respiratory system. I'm a bit over time. These are some numbers on the development of untreated patients with decline in FVC and MEP. And I think the consequences are very clear if you don't treat these patients early enough. It's a severe and dramatic reduction of quality of life in these patients. And I think it came out that it's very important to test these patients for respiratory involvement. I'll just run over these slides. You can see on the screen, of course, you can do something. You can train these respiratory muscles as you can train your muscles of arms and legs. So think about this in any patient who has a moderate or slight reduction of respiratory muscle strength. They might benefit from respiratory muscle training. And this, you don't have to have extensive or significant or expensive devices. It's very easy. So this is something physiotherapists recommend: breathing through a straw, inhaling. As the longer the straw, the higher the resistance. The smaller the straw, the higher the resistance. If a patient is not able to breathe or inhale with a straw, just tell them, just cut the straw in the middle so the straw gets smaller and the resistance is reduced. It's a standard treatment in these patients. And these devices here, like this one here, is about 50 euros. And what we want to have is a fully inflated lung, because if the lung is not inflated, this is called atelectasis or dystalectasis, we have the higher risk that we have areas in the lung volume that are not playing in the system of oxygenation. So the amount of functioning lung tissue is reduced, and within time the oxygenation is reduced. And this is just one highlight in one patient with familiar ALS. It's not only about the diaphragm. This is something I wanted to show you. So respiratory symptomatic treatment can also be done by moving the stomach and the lumbar spine. This is what the patient is doing. She has severe ALS and she is invasively ventilated. And the physiotherapists tried to figure out whether she was able, just by movement of her lumbar spine. And what you can see over here is that she is able to, just because of their elastic retraction of the diaphragm, there's a small movement of the diaphragm just because of the abdominal organs that are moving, and she's able to inhale about, what is the FVC here? 0.3 liters. That isn't much, but it's enough for this patient to be off her invasive ventilations for up to 4 to 5 times for 30 minutes, which increases her quality of life dramatically. So even with these techniques, some patients might be able to have some ventilator-free time. Okay, these are the practical care recommendations, the combination of all the practical recommendations we currently have. I recommend at least biannually in stable patients, in patients who have first signs of respiratory involvement at least annually, in patients with symptoms at least every 6 months. And I think it was very clear, just talk to the patients about the symptoms. Thanks. Any questions? Yes.
Thank you for this very comprehensive talk. I had 2 questions, and the first one was, how do you assess lung function when you have not enough cognition or not enough motivation to do a good lung function test?
That's tricky. It's not easy. So the FVC in some patients might not be measurable. So we reduce this just to the MIP and the MAP. So it's one short inhalation against resistance and exhalation against resistance, and we try to figure out by some equations whether this is a normal lung function or not. But it's tricky and it's hard, yes, of course. But the MEP and the MEP is very easy. So even patients that are not working or not motivated, they might do these tests.
And my second question is on the quality of life, because it is on one hand that if you don't do any treatment, your quality of life decreases, but also the ventilation can decrease quality of life. So what is your opinion about this, or your knowledge?
So my opinion, so I can talk frankly, honestly. So if you talk to patients and say, well, we have a decreasing lung function or a decreasing respiratory muscular strength, and you might develop respiratory insufficiency, we have part of patients who say, I don't want a ventilation. But as soon as they get more and more symptomatic, they come back and say, okay, let's try this, because the reduction of my quality of life is so immense, I will lose my job. I can't do anything per day because I'm so tired, I'm so fatigued, I need a treatment. And as soon as you do the treatment, and there are so many studies that reflect that if you are ventilated for at least 4 hours a day, this increases your energy level dramatically. So these patients will stay with ventilation, and they will say that the ventilation is more important than staying without ventilation and having a decreased quality of life. In fact, honestly, you have to wait until these patients might develop severe symptoms, but they're coming back, definitely.
One in the back.
Thank you for the great talk. I have a question on the blood gas analysis and in clinical practice. To early detect positive ventilatory impairment, is the hypercapnia that notable that a venous blood gas analysis would work, or would you need an artery or a capillary analysis?
You can do venous assessments, but you have to have your own numbers of patients to understand what happens in venous blood. So we do capillary blood gas analysis. We even don't do arterial.
So just a quick, first thank you for a great talk, a quick comment and then a question. The comment would be for the congenital muscle diseases, it's probably respiratory failure is probably the highest cause of morbidity and mortality, and we can't ask children for symptoms, so we're extremely proactive. So you can add to the diaphragm weakness list, collagen 6-phase dystrophy, severe diaphragmatic weakness, and so we just basically use capnography and FVC as a surrogate measure, and then try to start BiPAP before we even get a sleep study because we have a long wait. So my question is, would you recommend trying to do capnography and FVC to kind of figure out who should be on BiPAP and then try to do BiPAP without a sleep study?
It's not that easy question.
I'm just curious because during COVID it was impossible to get sleep studies.
Is.
So a lot of my colleagues did a PAP-NAP in clinic where they would start BiPAP in the clinic, and I wonder if we could just maybe kind of pitch that to the pulmonary world, maybe.
So I'm a neurologist with neuromuscular patients. So I'm not talking to you as a pulmonologist. I'm not one, but every pulmonologist would say don't start BiPAP. Normally it's CPAP that is sufficient. I had a long discussion with pulmonologists, and they say CPAP is sufficient, and I say no. And we have many patients who start with CPAP, like myotonic dystrophies, who have a clear obstructive sleep apnea. But the moment when we have to change the CPAP into BiPAP because they're developing respiratory insufficiency, that is a really hard measurement and really, really hard to figure out when is the perfect time. And it's always a discussion with the sleep laboratory or the pulmonologists, always. So the main problem is we don't have capnometry for outpatients. So we always have to do this in inpatient clinics because that's pretty expensive devices. The only thing I've heard is that in Berlin, I think, they have introduced a very small FVC device that is connected to your mobile phone for myasthenic patients, and they're as often as they want, 3 times per day or less or more, they're testing the FVC. But I think our problem is that capnometry is not available at home for patients. And this would be I think we would detect more patients with respiratory insufficiency if we had this.
I agree. And the BiPAP argument's always, I think, uniformly hard for all of us as neurologists, but most of the time it is BiPAP, rarely CPAP. It's a kind of uphill battle, but yeah. Thank you. Thanks.
Okay, cut 13 minutes.